Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome to this episode of Thinking Thoracic, Raising the Bar, Redefining Lymph Node Evaluation in Lung Cancer Surgery. I'm your host today, Jeff Yang, and today we'll be discussing 3 studies presented at this year's STS annual meeting in New Orleans, including the Richard E. Clark Memorial Paper that was presented by Alex Potter and the Maxwell E. Chamberlain paper presented by Chris Seder. I'm joined here today by Dr. Chris Seder, who is the Arthur E. Diggs L. Penfield Faber Professor of Surgery and Chief of the Division of Thoracic Surgery at Rush, Dr. Seth Krantz, who is the Chief of Thoracic Surgery at Endeavor Health and Clinical Associate Professor at University of Chicago, and Alex Potter, who is a medical student at Harvard Medical School. She's not yet a surgeon, but certainly an expert in this field, having published over 60 papers, including leading major studies published in JAMA, Journal of Clinical Oncology, British Medical Journal, and JAMA Oncology. Well, welcome to you all. Thank you so much for being on here today.
Thank you.
Thanks, Jeff. Great to be here.
Great. So today's topic, we're going to look at 3 papers that were presented at the STS that were very innovative and really are going to help us rethink lymph node evaluation in lung cancer surgery. As many of you know, the STS General Thoracic Surgery Database recently started capturing individual lymph node stations back in 2021. And so this gives us a much more granular look at how we're doing in the operating room, both at individual centers and also nationally. And so Seth, why don't we jump to your paper first, which is on the National Assessment of Adherence to Commission on Cancer Standard 5.8 for non-small cell lung cancer and its impact on nodal upstaging rates and operative morbidity. Can you share with us a little bit about the context for this study, how you came about it, and what some of the take-homes were for it?
Right. So the background is that the Commission on Cancer, part of the American College of Surgeons cancer programs, was really one of the largest accrediting cancer bodies in the United States. And they put out their guidelines and standards for quality cancer care. Previously for lung cancer, they had a lymph node standard where centers, in order to be compliant with this standard, had to have greater than or equal to 10 nodes. But we all know there's some issues with node counting, especially with minimally invasive approaches. That's more than robotic, but really any approach, the node fragmentation coming out in pieces, what's really 1 node, what's 4 nodes, right? And so in 2022 into 2023, they changed the standard to a station-based standard. Where in order to meet the standard, it was 3 mediastinal or N2 stations and 1 hilar station or N1 station. So the 3 plus 1, and that's how you met the standard. And ultimately, to meet the standard, 80% of a center's resections, so individual curative resections for lung cancer, need to meet that standard, the 3 plus 1 standard, for a center to be compliant. What we wanted to look at was to utilize the STS database to see, at least early on, what type of impact that would have in short-term outcomes. And one of the benefits of the change in the STS database with being able to look at stations, we were able to actually see at the individual resection level, right? So every individual resection for lung cancer, but then also at the surgeon level and at the center level, right? Whether or not the resections met that 3 plus 1 standard, right? So what we found is that in terms of compliance early on, adherence was actually relatively low. So in 2021, 19.3% of centers were compliant. right? So in terms of a center being compliant, it was 80% of their resections, right? That increased to about 43% in 2024 by the end of the study period. So it improved, but still only was at 40%. And surgeon level trends were similar, 23% to 44%. In terms of overall throughout the entire STS database, right, just the total number of resections, 66% over the entire study period met the standard for that, with an increase of 54% from the beginning till 75% at the end. So a greater percentage were meeting the standard by the end. Great. What's the impact of that? So what we wanted to know, is there a clinical outcome in meeting the standard? And in terms of short-term outcomes, the most direct outcome that we can get from the STS database, which is really a surgical outcomes database right now, 30-day outcomes, is the nodal upstaging. If you're looking for more nodes, are you finding more cancer? And so that was the main take home from the study. So in terms of nodal upstaging, right, there was a significant increase in upstaging for patients who had and met the standard for those who didn't. So patients, or I should say cases, resections that met the standard, 11.5% were upstaged who met the standard. For those that did meet the standard, it was 8.5%. And with an adjusted odds ratio of 19%. So almost a 20% higher odds ratio of upstaging in those patients who met the standard. And importantly, there wasn't any significant increase in major morbidity, and specifically in recurrent nerve injury, chylothorax, complications that we would traditionally associate directly with a lymphadenectomy or a more aggressive lymph node dissection.
Great. And I think that really speaks to the power of this database, being able to have not just the types of lymph nodes that were dissected and that's being collected now, but also the specific morbidity and mortality information. For Chris, I'm curious, as you see these findings, how do you think this is going to shape our quality metrics? Obviously, we're going to talk about the two papers that you and Alex led, but just this study alone, what are some take-homes for you about thoracic surgery in the U.S. in 2026 and beyond?
Sure. So taking out lymph nodes is important. That's, I think, the kind of one of the biggest things here, and I think we'll see that recurring theme throughout all three of these papers that we discussed today. And as we in the Society of Thoracic Surgeons general thoracic surgery databases, we look at various metrics. Lymph node assessment is one that we've talked about, that we've considered. However, at the current time, the Commission on Cancer has done an excellent job with the 3+1 standard, and we don't necessarily, we have not yet, or do we necessarily intend to, create a lymph node standard based on the current data that we have.
I think those are great points. This was really powerful study, Seth, because it's really showing that the guidelines matter, that this is working. And I was curious, Seth, for you, was there anything surprising that you found as you were doing this analysis?
It's a great point, Jeff. I was a little surprised at actually the low level of adherence to start, even within the STS database. We, have looked at other studies, and it's frequently commented on that the STS database is not, it's representative of a large group of general thoracic surgeons, but it's often board certified, people who focus in general thoracic, and sort of inherent in that is somewhat the implication that the outcome should be better, that it's a higher quality or standard compared to a regular nationwide inpatient sample. And so to see 19% adherence to what I think is a relatively easy standard to meet, 3+1, right, and then 40% by the end, surprised me that was lower. Now again, we included lobe segment and wedge, and we started in 2021, and so part of the wedge resections and even the segmentectomies were before the publication of CLAGB and JCOC studies. So some of those were probably being done in patients who are not quite medically as fit. How that affects the lymphadenectomy, we don't quite know, right? It may be different to look at it in an era purely when patients who are getting those operations, it may be not because they're compromised physiologically, because of less aggressive tumors. And so I think that was a surprising thing. The one thing I'll note is that this was, I wouldn't say in collaboration necessarily at the COC, but they have a committee. I serve on that committee investigating standards. So I think we're going to see from the study that Alex is going to discuss and where Chris is going to go, this is a standard. It's good to have a standard. The COC themselves is not, I don't speak for them, but any standard is not wedded to. Part of the process is an iterative process to find out what's the goal of the standard and is it working. And so I think that all of these papers are a step towards that direction and saying we need a standard, right? But we need to continually evaluate how they're working and be iterative to get to the right standard and evolve that over time if we get as the data evolves.
I think that's a really great point, Seth. The STS, as we had mentioned, has been traditionally this short-term database, one that we look at primarily 30-day morbidity and mortality. Well, as most people know, over the course of the last couple of years, we've been incorporating long-term outcomes. So we've been incorporating overall survival linked to not only CMS data, but also National Death Index data. And so now we can not only look at the short-term outcomes, but we're going to be able to link that to the long-term outcomes. And I think that's going to be an important part of determining what standard is best, because the oncologic outcomes of what we do is kind of the core of it. And I think you also mentioned, Seth, that, maybe not all patients need a full lymph node dissection. Maybe they do, maybe they don't. One of the things that's going to help us, there's certainly really good data out there that says, the rate of nodal metastases from pure GGOs that are peripheral and very small is not that high. And so do you need to take all the lymph nodes for that patient? Unclear. But, the STS is positioning themselves to help provide data to, be in the conversation as we figure that out. We're in the newest revision of the data collection form. We're collecting data on, consolidation to tumor ratio, genetic makeup, as well as a number of extra pathologic factors, SUV max, things that can help us maybe narrow down just a little bit on who needs what lymph node dissection.
I mean, listen, every cancer is different, right? They're not the same, and even types of cancer. That doesn't mean we can't learn from our breast surgery colleagues, right? And where they're going with lymph node assessment. And I think maybe we'll talk about it, right? Is it, well, we still don't know, is it the removing of the lymph node, or is it the determination of who benefits from adjuvant therapy? And it's our abilities to determine that with lymph node dissection, along with tumor, sort of proteomics and other factors, and looking at the totality of it, right? How all these evolve and the risk for metastases is an interesting and exciting time in terms of improving care overall, to be more aggressive when you need to and be less aggressive when you don't need to. There's an interesting Chinese study that's looked at it, right? They presented this a couple of times. It's a showing that we do minimally invasive surgery, right? But then they show what the lymph node basins look like before we touch them and then after a complete dissection. So it's small incisions, but maximally dissecting all of these lymphatics, and how does that interact with immune therapy? So figuring all of this out, I think, we're right just at the beginning of that, and how that ties into cancer outcomes is really going to be the key.
Exactly. And I think that's a great transition to the two papers that are looking at some of these quality metrics and what might be the optimal approach to nodal sampling, because currently that's still unclear. So Alex, we'll turn to your paper, and just as a little bit of a background, so we talked about the COC, the NCCN and the American College of Chest Physicians, they also recommend at least 3 mediastinal lymph node stations and 1 hilar station. The European Society of Thoracic Surgeons, they advocate for a lobe-specific nodal sampling approach, meaning that based on what lobe you're resecting, the nodal sampling strategy is going to be different. And then studies from Japan have also proposed lobe-specific nodal sampling strategies. So, for example, in Japan, if you do a right upper lobectomy, then you would have level 2R and 4R taken out, but you'd skip number 7. So in that setting, Alex, would you like to talk about what you found in your study?
Absolutely. And so as you were mentioning, there's a lot of variety in the different types of recommended nodal sampling strategies right now. You mentioned the ACSCOC, you mentioned that the NCCN and CHEST both also recommend 3+1 sampling strategy. The ISLC actually recommends a 3+3, so 3 mediastinal stations and 3 hilar stations. So there's a lot of variation, and it's unclear what the optimal strategy is, if there is one at all. And so for our study, we built off of the excellent work that Dr. Krantz did by looking at what the nodal upstaging and major morbidity and mortality rates were for different nodal sampling guidelines using the same database, the STS-GTSD. We looked at several guidelines. We looked at the ACSCOC Operative Standard 5.8, which recommends sampling of at least 3 mediastinal stations and 1 hilar station. We looked at a modified version of the European Society of Thoracic Surgeons guideline. We looked at the Japanese lobe-specific or a lobe-specific guideline based off of studies from Japan. And then lastly, a hypothetical 2+1 guideline, which is like standard 5.8, but instead of recommending 3 mediastinal stations, recommends only sampling of 2 mediastinal stations. Our key findings for the paper were like what Dr. Krantz found was we found that patients who met any of the nodal sampling guidelines had significantly better nodal upstaging rates when compared to patients who met none of the guidelines. And I'll back up and first just say, describe like what proportion of patients met each guideline. So in our sample of about 47,000 patients, we found that 69% met operative standard 5.8, 32% met the modified ESTS lobe-specific guideline, 26% met the modified Japanese guideline, and 84% met the hypothetical 2+1 guideline. 16% of the cohort met none of those guidelines. We found that nodal upstaging rates for patients who met any of those guidelines ranged from about 11.5% to 11.7%. So they were really quite similar, no matter if you followed the ACSCOC standard or the STS lobe-specific guideline, essentially the same nodal upstaging rates. However, for that 16% of patients who met none of the guidelines, the nodal upstaging rate was only 7.6%. So again, nodal upstaging rate significantly higher if you met any of the guidelines compared to none of the guidelines, in line with what Dr. Krantz found when comparing ACSCOC to none of the guidelines in his paper. The other key part of the study was looking at major morbidity and mortality, and we found that major morbidity and mortality were nearly identical across the 4 different guidelines. It ranged from 5.2% to 5.3%. And when we compared major morbidity and mortality among patients who met any of the guidelines compared to none of the guidelines, we found that there really wasn't any difference. Major morbidity and mortality were 5.2 to 5.3% among patients who met any of the 4 guidelines compared to 4.9% among patients who met no guideline. So really quite similar. Importantly, these findings were consistent in multivariable adjusted analyses, and they were also consistent when we looked at the subgroup of patients with stage 1 disease only.
Thank you, Alex. So I think when it comes to some of the take-homes that I got from hearing you present about this, the main thing is it does seem like in the STS database, the thoracic surgeons who are doing some kind of nodal sampling strategy, whether it's lobe specific, whether it's 2+1 or 3+1, that they're figuring out where potentially the lymph nodes that matter are that need to be dissected. And I'm curious, when you were doing this analysis, did anything surprise you, or were there any insights that you felt that were important to highlight?
Yeah. So one of the interesting findings was that when we looked at patients who underwent wedge resection, we found that nodal upstaging rates were similar when patients met any of the guidelines when compared to none of the guidelines. So among patients who underwent wedge resection, nodal upstaging rates were 4.5% to 5.6% compared who met any of the guidelines compared to 4% among patients who met none of the guidelines. So this benefit in nodal upstaging that we found associated with meeting any of the guidelines was observed primarily among patients who underwent lobectomy, and then to a lesser extent among patients who underwent segmentectomy. But the difference in nodal upstaging, there wasn't a very large difference when looking at that subgroup of patients who underwent wedge resection for stage 1 disease. And one of the our hypotheses to explain that finding was that even though patients might be getting sufficient N2 sampling, the N1 sampling, they may only be getting one nodal station sampled and may not have as extensive N1 sampling compared to patients who were undergoing more extensive resections. And I think that finding aligns well with Dr. Seder's paper, and I know he'll speak more about that, about the importance of N1 sampling during intraoperative sampling.
Thanks, Alex. That you presented that paper extraordinarily well, and one of the things that makes me wonder is, alluding back to what we were talking about, is it that patients who had lower risk tumors, as deemed by the surgeon, got wedge resections, and for that reason they were less likely to have nodal upstaging? It's hard to really sort that out with the data that we have.
Absolutely. I completely agree. And those patients tended to have smaller nodules. The STS GTSD does not include data on nodule attenuation or the percent ground glass component or FDG avidity. So we weren't able to look at any data that might give us some insight into how aggressive these cancers were. But I think that's a really important point to keep in mind when interpreting these data.
I mean, I think to that point, Alex, and to Chris, right? There's the broad data. Like, we have to be able to look at this in huge patient numbers because it gives us information. But when you're doing this every day, right? Even those of us who are really attuned to this data and the importance of lymph nodes, there's people we're taking who are relatively healthy and they have a small tumor, like we said, that's on the edge of the lung, even if it's solid, but it's on the edge of the lung. It's in a gets into what's a quality wedge. That's not quite this focus of here, but in a pleural reflection where you could hug your stapler, right, almost against the vessel, get a huge margin on it, and they have a beautiful fissure. You see 4 nodes there. You're going to take them. You're taking all the nodes. You're essentially doing a segment without touching the lung, right, and they get a great dissection. There's another group of people who, they meet the CLAGB criteria, right, but they got bad emphysema. Their fissure is like a bread loaf. Right. And you're going to get a good margin on it. Right. And, you're justified in doing that operation from good data. And you're also thinking about the patients maybe a little compromised. So a wedge is good here. You'll get some N1 nodes, but you're probably less likely to go attack that fissure, which isn't open, and try and get things from there. Like, you're limited there in that respect by those things, which we'll never really be able to capture in the database, and is the challenge of that, and even on a segment, and why you'll get more on a lobe. Now, does that patient I described need a lobe, though, right? We have studies that say they don't. And so where does that nuance come in? But that's why some wedges will get great nodes, right? We all see those in the operating room, but it's hard to tease that out. And we'll never tease that out really in database data. And that's okay, but I think it's worth noting.
And one of the things that hearing, both Seth's paper as well as Alex's paper, we are seeing a trend over and over that more extensive or less extensive lymph node dissection doesn't really seem to change morbidity or mortality. And we've seen that trend in the literature for decades now, going all the way back to the Z0030 trial, where, a lymph node dissection versus lymph node sampling, really showed no difference in short-term morbidity. So I think that's one thing that we can probably take home as fact.
Exactly. That's Chris. Is exactly the point I was gonna say. Was that what was very reassuring about Alex's study is that the morbidity and mortality rates were almost identical between either the 4 guidelines or the patients who did not have any guidelines. So the M&M rates were about 5%, and these findings were consistent even after multivariable adjusted analysis. So I think that the safety of lymph node evaluation has been clearly demonstrated here, and that what's also clearly been demonstrated is that it's better to have a strategy and better to have it be consistent with a guideline, which I think will turn us, give us a good transition into your analysis, Chris, because I think your study really takes it to the next level about trying to figure out what may be the optimal approach. But before I do that, I do want to give a big shout out to both Alex and Chris. Alex's paper was the Ritchie-Clark Memorial paper, and then Chris, your paper was the Maxwell Chamberlain paper. And so really appreciative of opportunity to highlight both of these papers as well. So, all right, but Chris, to you on a little bit of context and what you found in your study.
Sure. Yeah. Thanks, Jeff. So as we've talked about, despite the guidelines that, we have from the COC or in different parts of the world, different societies, we know that lymph node evaluation practices continue to vary pretty substantially across the U.S. and across the world. And that's probably driven by the fact that we have no universal guideline. And the question is, really for us, what is the best lymph node dissection practice? And if you look into the literature, most of the data out there has focused on number of N2 lymph nodes that need to be evaluated. And there's a whole lot less on N1 lymph node dissection and how important that is. And we hypothesized quite simply that a more robust N1 nodal assessment was associated with higher rates of upstaging, which is, sounds pretty intuitive, but it would also result in more accurate stage stratification. And so we looked at all patients, again, from 2021 to 2024 who had wedge resection, segmentectomy, or a lobectomy that were clinical N0. And we looked at rates of upstaging in these patients of finding of occult nodal disease based on the extent of lymph node dissection. And we also took those patients, and in those that were pathologic N0, we linked them to National Death Index as well as CMS data to look at their overall survival to see if we could better stratify patients and identify more occult lymph node disease by doing a more extensive lymph node dissection. And as I said, our primary outcome, our primary endpoint was pathologic upstaging. So our cohort looked very similar to both Alex's as well as Seth's. They were mostly lobectomies, about 65% lobectomies, and 17 or 18% of wedge resection or segmentectomies each. And we found overall that about 11% of patients were upstaged. Now, we broke this down, and you could imagine a grid with N1 nodes across the top and N2 nodes along the side. And then we looked at the rate of upstaging if you've met, let's say, 1 N2 and 1 N1 and 1 N1 and 3 N1 or 3 N2, and so on and so forth, and broke it down. And looking at just the patients who are COC compliant, meaning they have at least one N1 node and at least 3 N2 nodes. If you look at the rate of nodal upstaging for patients who had one N1 node station evaluated, it was 7.8%. If you increase that to 2 N1 stations, it goes up to 11.8%. And if you increase that to at least 3 N1 stations, you get a 15% rate of upstaging. So we're talking about meeting the very minimum of the COC 7.8. You essentially double that to 15.3 by taking 3 or more lymph nodes based on our data. And one of the things that was really important here is we broke it down by, where did those N1 stations come? Where did those N1 nodes come from? And about 20% of patients who were upstaged, 20% of those 11% of patients who were upstaged, their only positive node was a station 12 through 14 lymph node. And this is a really important point because, very often, as Seth said, people are doing a wedge resection and then digging out a hilar node and, or maybe a station 10 lymph node. And you could potentially be missing, occult metastases in these station 12 through 14 lymph nodes. Again, we found no difference in morbidity or mortality when broken down by the number of lymph nodes taken from N1 or N2 stations. As we linked patients who had pathologic N0 disease, and we looked at their adjusted hazard ratios for survival with approximately 2 years of follow-up, which admittedly is a short median follow-up. But as we looked at their adjusted hazard ratios, it was protective to have 2 nodes over 1 node, and even more protective to have 3 N1 nodes taken over 1 node. And again, you look at those hazard ratios for those who had station 12 through 14 taken versus not, and we again see that it's protective to take station 12 through 14 lymph nodes. And so based on all of this, we concluded quite simply that assessment of more than one N1 station, including those station 12 through 14 lymph nodes, is associated with increased upstaging and improved stage stratification. We're better able to, pull those patients out of pathologic N0 by doing a better node dissection.
So Chris, that was a lot of important analyses and findings that you just presented. And I was wondering if you could talk a little bit more about the rate of node positivity across the stations. Did it vary?
Mm-hmm. Yeah, it's a really good point, Jeff. We broke it down by the individual stations. So what percentage of station 2 were positive? What's percentage of station 4? So on and so forth. And as I mentioned, those station 12 through 14 lymph nodes are very important. 8% of the time that those are sampled, those are positive. Whereas take, for example, station 2 lymph nodes, only 2.2% of the time, those are positive. And this is when the manuscript is eventually published, we'll be able to show this. This is actually a table in the manuscript. And it's quite striking, the variation. There's 10-fold differences in rate of nodal positivity between some lymph node stations and others, with the highest by far being the station 12 through 14 lymph nodes. So those deep intraparenchymal lymph nodes seem to, really be important. And that's not surprising. Those are the closest nodes, the first, level of drainage from these tumors.
Exactly. And for Chris, Seth, and Alex, what is your take on that finding in terms of, so for thoracic surgeons, we're in charge of the mediastinal stations, right? We're the ones solely in charge of that. But when it comes to N1, it is a collaboration between surgeons and pathologists as well. And so I was curious how you interpret those findings in light of the fact that N1s get evaluated by both surgeons and pathologists.
Sure. I could take a crack at that really quickly. You're right. It's a joint effort. There's things that surgeons can do. And so the things that I think surgeons can do to increase the number of N1 lymph nodes taken are, number one, as we do more and more robotic surgery, I think many people would agree that it's easier to do the lymph node dissections deep into the lung. And as we do that, putting in the little bit extra time to dissect those, station 12 lymph nodes out, which Used to be really hard to do VATS, not impossible, but more difficult. Doing that robotically, I think is perhaps going to prove to be the right thing to do. The other things, it's been shown by groups that having a tackle box in the operating room with individual lymph node stations sampled encourages surgeons to actually take more lymph nodes from these different stations. So simple things like that are things the surgeons can do. There are also studies, though, interestingly, that show that education and hard stops by the pathologist, by the attending pathologist, when no intraparenchymal lymph nodes are reported out, can increase the rate of lymph node identification. So there are pathologic protocols. This is as much of a call to action to pathologists as it is to surgeons, because you're right. Oftentimes, if you do a lobectomy and you're, presumably every time you do an anatomic resection, you're taking a bunch of station 12 and 13 and 14 lymph nodes. I don't know any surgeons that cut the specimen apart in the back table unless it's part of a TSOG trial or one of these things that do that. So, it's on the pathologist as well. And I'd like to, we should get this word out to them as much as surgeons.
And I wonder, some of our role is also educating if we're doing more wedges and segments, because the reality is that there's wedges that are your diagnostic wedge when you do a wedge lobe, which we do less of, right? The smallest amount possible. And there's a true oncologic wedge or segment where you might, adhere to some form of a segmental boundary or plane. You're taking a reasonable amount of lung parenchyma. There's probably some nodes in that. But I do suspect that the pathologists get that and they see wedge, even if the specimen is the size of a segment with your wedge, right? We're not talking about the wedge you do for an ILD case where your margin's 5 millimeters, where you are taking a segmental piece of tissue, right? There's got to be some nodes in there, right? And I wonder if, they don't see lobe and they see wedge, there's an education, there's more of these coming. We need to treat it with the same degree of care, and it's interesting grouping the 12 and 14 together, because the reality is that probably should just all be grouped together. When we get there, we know there's a lot of surgeon discretion. Is that an 11 or is that into the 12, or is that really a 12 lobar, or did I get it between the soup sag and the basilar trunk on a lower lobe? So is that actually a 13, right? Like if it's between there, is that a subsegmental? Is that an intersegmental, right? Or is it a lobar? And so we all, we know how they're defined, but when you're in there and the confluence of the nodes, and so I think, knowing the broader principle that out in the lung parenchyma, the nodes that potentially are not just the surgical nodes, right? Individually dissected surgical nodes, I should say, really do drive it. And to your point, pathology education, adjunct tools, these light boxes that look at things too, are all going to be important. But I think as we do more wedges and segments, right, even if it's a very good wedge, which a large amount of parenchyma, or large meaning relative, is sort of in an oncologic perspective, there should be some intraparenchymal and level 14 nodes and beyond in there. And I think some of that's education that, hey, this needs to be dissected out the same way that a lobe would be.
Great point, Seth. In terms of, so there are 3 papers that we're discussing today, and each highlighting a different aspect of lymph node evaluation. I guess I'll throw it out to all of you in terms of some of and there are a lot of numbers out there, a lot of numbers. What are some take-home numbers to get in the back of our minds to, as we start internalizing some of this and figuring out how we're going to either improve our own practice or improve our center's practice, or even as we think about designing the next studies on this topic. So Seth, I'll go to you first. You could just summarize some of the main numbers you think that are important for us to remember.
Yeah. I think the big take home is the upstaging. Just think 11.5, 12%, right? Compared to 8. It's 11.5, 8.5, but 12 and 8, right? Rounding for a metric, right? How do we define a quality node dissection? Right now, at least, and then maybe this has to be continually evaluated as our upstaging rates change as we find tumors smaller, but there should be some level of upstaging, right? And multiple studies have now shown that as a target, when you're looking at your own quality, you're doing it right, your upstaging should be north of 10% right now based on the staging we have. And so that difference of sort of 11.5%, 8.5%, for meeting the standard and not meeting it, I think is important. I think in terms of quality, to know where we're at, where we have to get to, there's 80% of resections should meet the standard. That's the COC standard. In the STS database at a surgeon level, in the most recent look, only 43% of surgeons were. So we as a group, just in knowing how we're doing overall, we have a lot of work to do. And that only 43% of centers, the same thing, had 80% of their resections meeting that standard. So the COC gives you wiggle room there, right? In case you had one where you just couldn't find any nodes, or it was a total fibrothorax and you decorticated it. But even only 45% essentially of STS surgeons in 2024 had 80% of their resections meeting the standard.
Great, thank you, Seth. And Alex, we'll turn to your study.
Yeah, so when you look at operative standard 5.8 versus the other different guidelines we looked at, the modified ESDS slope specific guideline, modified Japanese guideline, this hypothetical 2+1 guideline, the nodal upstaging rate was about 11.5%, consistent with what Dr. Krantz found in his study, and didn't matter which guideline you met. As long as you met one of them, you were going to get about 11.5 to 12% nodal upstaging rate. This was notably higher compared to patients who did not meet any guideline, only a nodal upstaging rate of 8%. And an important finding is the major morbidity and mortality rate. No matter which guideline you met, if it was ACS-COC or if it was one of the more lobe-specific guidelines, the major morbidity and mortality rate was 5%. And that was very similar to the major morbidity and mortality rate for patients who didn't meet any of the guidelines. So really a very low major morbidity and mortality rate.
Great, thank you. And Chris, we'll turn to you. Part of the reason why I wanted to ask this question is I wish our listeners I wish you could just beam in that really cool figure, the grid with the N1, N2 and things like that. So, but if you could say it one more time and highlight some of the important numbers from your study, that'd be great.
Sure. Yeah, thanks. I think that, keeping it as simple as possible, if you take 3 or more N2 nodes, if you take one N1 node, you have a 7.8% rate of nodal upstaging. If you take 2, 11.8. If you take 3 or more, 15.3. And 20% of patients that were upstaged through only exclusively station 12 through 14 lymph nodes.
Great, thank you. That was great. And I think we only have time for a couple more questions, but I wanted to see if you could all weigh in on what the next studies should be on this topic. So, Chris, I'm really glad you pointed out that the STS is starting to collect things like PET avidity, tumor consolidation ratio, and things like that. I'm curious, maybe we could just jump to, if we all could do a dream randomized trial evaluating some of these different strategies, what you might do, what you might compare, or what kind of strategies you think need to be tested in light of this data. And maybe Seth, I'll go to you first.
I mean, I would like to see a trial. You put me on the spot. I'm going to edit. So, I mean, I think being able to do a trial where you're comparing nodal strategies, including a strategy of selective, of limiting nodal assessment in extremely low risk cancers, right? That thinking, looking, is that okay, right? Part of what we're looking at is there's no difference in morbidity when you're not meeting the standard. We don't know what the difference is to not going after nodes at all. We've said that we should, right? And I agree. This is not to be like to take home is don't look at lymph nodes. But if there are really low risk cancers where you really don't need to, right? If you're not touching the basins at all, what is the difference there, right? And are those patients where you can do that? It's a simpler operation. It's like we may see some differences there. So looking at a strategy that looks at tumor type, sort of some stratification, that includes various strategies, a more aggressive, probably N1 strategy, versus, clinical staging of nodes only in certain very low risk tumors, and comparing that, even if it's not randomized, something very prospective where we're looking at it with specific outcomes would be really great. And the part that I would add to it, where do the adjuncts play in terms of looking at risk of recurrence and determining chemotherapy in these stage 1 patients? Can some of those tests rescue maybe some of the patients in Chris's study who had less extensive N1 evaluation? There's obviously commercially available tests. I know, Chris, you had published a study years ago looking at different proteomics and tumor genomics for risk of recurrence. But, how do these play in? They use it in the breast cancer world and, in terms of need for chemotherapy. How does that play in? Because that would really tell us, is it the removal of the nodes or is it getting the appropriate patients to adjuvant therapy? So those are the two big questions I have. Who can we avoid it on? And what's the role of adjunct tests to determine who needs chemotherapy to guide our lymph node decision making?
I think those are great points. And I'm glad you brought that up because, for example, I think some of us or many of us are now familiar with the study that was published in JCO by Haiquan Chen and their team in China, looking at the more indolent tumor types, so tumor consolidation ratio less than 0.5, and randomizing to no lymph nodes dissected versus lymph node dissection strategy, finding no difference. And I wanted to highlight that in that study, everybody had anatomic lung resection. So there were no wedges in that resection. But we probably do need to have a trial like that in America, looking at U.S. patient populations. Alex, I'll turn to you. What would be your dream trial on this topic?
I think before a trial, it would be really helpful to have better data to understand how to risk stratify patients into high risk for nodal mets and lower risk for nodal mets. We have some markers of that, like if it's a GGO versus a solid PET-avid nodule. But just having better data to understand this patient has a really high risk of nodal mets and would probably benefit from a more intensive intraoperative nodal dissection. I think the STS GTSD might be a really exciting database to start to answer those questions, especially as these data like consolidation tumor ratio, FDG avidity, other more not necessarily novel, but other measures that can better help us better understand risk of nodal mets. So I think looking at that will be really helpful. And then I would love to see a randomized trial where you risk stratify patients up front, and in the low risk patients do like a non-inferiority design where you test the current standard versus a less intensive standard and see if the less intensive standard does just as well. And then in the high risk patients, test whether a more intensive strategy is superior to the current strategy. So a little bit of both, some retrospective data to better inform the risk stratification, and then a trial to identify the best strategies depending on patients' baseline risk.
Exactly, like a trial to test more N1 or more intense N1 sampling. I think that's great. Thank you, Alex. And then one other really interesting thing is I think with AI and image-based AI in particular, there is an opportunity to start to see if we could apply an AI algorithm to the pre-op chest CT, and if that could help us with risk stratification beyond the clinical factors that we currently have access to. So I think there's a lot of really exciting new pieces of data coming out that could really help us better understand who's at risk. Great. Thank you, Alex. Those are great points. And Chris, we'll turn to you on that question. And then also if you could weigh in on whether or not you feel the STS or just organizations in general, if we ought to be changing our guidelines now, based off of these studies, or if there's still some other things that have to be investigated first. So
sure, yeah, I agree with what Alex and Seth both said, and another, just adding on top of the AI component, not only radiographic assessment, but AI assessment of pathologic specimens can help risk stratify, patients' long-term, outcome. And so if we could somehow give patients a risk score based on all of these things, not only their clinical data, but their radiomic data and their genomic data and their pathologic data, we would then, be able to test patients in each direction. The difficult thing is we're going to see a whole continuum of risk, and what kind of numbers would we need in a clinical trial to show that at this risk level you need this node dissection, at this risk level you need that one, and high risk you need a different one. It would be a lot of patients. So I think those are some of the challenges that we struggle with up to this point. And so to your other question, Jeff, about should we change our guidelines today? Well, I think that the data that we have are pretty strong. They're but they are retrospective, and administrative. Retrospective database analyses are not perfect and have a number of different biases, and we don't assess necessarily all the things we've talked about. And so as time goes on, we will be able to narrow down on this better with the Society of Thoracic Surgeons database. And I think that this will be a committee, decision by committee. Those making the guidelines will take these papers into consideration, I assume, and decide what to do with them. And the IASLC has already said that more than one N1 node is important. So it may very well go that direction, but I think it'd be premature or aggressive on my part to say that based on this study, everybody needs to have greater than 3 N1 lymph nodes taken. And part of that's because many of the reasons we discussed, but also because not every patient has lymph nodes in every station. And so you don't want to inappropriately say penalize a surgeon for not getting 3 N1 lymph nodes for a peripheral little tiny thing in an old sick lady. So that's those are the challenges we face.
Yeah, those are important nuances. I do think that the 3 studies that we're talking about today are very, very thought-provoking. They really do push the envelope, and they suggest that we need to reconsider what we think are the best lymph node evaluation strategies. And I'm so thankful to Chris, Seth, Alex, for you all taking the time to talk about these studies, and really look forward to what the next line of investigation that you develop in the future. So thank you.
Yeah, thanks for having us, Jeff.
Thanks, Jeff. This is great. Thanks for moderating it.
To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.